First of all, I'd like to acknowledge the fact that this is a big research team, and you have there the list of colleagues who are collaborators on this. And I'd also like to acknowledge NIH and NHLBI for their support. So what I'm going to talk about is the comparative effectiveness of 3 doses of behavioral weight loss treatment. And we delivered this through cooperative extension offices in rural communities. So it builds nicely on some of the work that we've heard earlier today. 2 key facts to start with. The majority of Americans are overweight or obese. And the second fact, though, is that the prevalence of obesity is higher in rural areas of the U.S. So the goals of my presentation are, first of all, to provide an overview of obesity and health disparities in rural America. And then I want to describe the study that we've just completed called the Rural Light Study. LIGHT stands for Lifestyle Intervention Treatment Effectiveness. This is an effectiveness trial. It was targeted toward obese residents of rural counties, and it was conducted via cooperative extension offices. What I'll do today is present this. This is a 2-year study, but I'll present the 6-month findings, particularly with regard to acceptability and satisfaction, and then I'll also present the preliminary weight changes. Defining rural. There are lots of different ways in which rural is defined. The Office of Management and Budget has a classification system for counties, and essentially puts them into 2 groups: metropolitan counties or urban counties, and then non-metropolitan or rural counties. So metropolitan counties are counties that include a city that has 1 million people or more, and those counties that are adjacent to a county with a large metropolitan area. It also includes small metropolitan areas. Those would be counties that have a city with more than 50,000 people in it. In contrast, non-metropolitan counties or rural counties are counties that have a city, but the city's population is less than 50,000, or they're a county that doesn't have a city. It doesn't have a town more than 10,000 people. Okay, some, I think, striking disparities between urban and rural areas. First of all, rural areas comprise 17% of the US population, roughly 50 million people. But 75% of all the medically underserved areas in this country are in rural. Rural areas have higher rates of poverty. They have higher proportions of residents without health insurance, and a greater percentage of people with chronic diseases. One of the things I think we need to be mindful of is that when we talk about prevention, particularly in the case of obesity, we're not just talking about preventing obesity, but we're talking about preventing the negative health consequences of obesity. So here's one example that illustrates the disparities in a problem that's related to obesity. So overall, if you look at the rates of death from ischemic heart disease, you see that they're actually higher in rural areas compared to urban areas. And nationwide, the region where this disparity is greatest, and the sex in which it's greatest, is for women who live in the South. So this is a problem of particular relevance to all of us in the Southeast Conference. Now, what are some of the contributors to that urban-rural disparity in heart disease mortality? Well, certainly poverty and low SES, limited access to medical care, virtual absence of preventive health services. Often people don't seek care until they're pretty sick. But there are also a constellation of lifestyle factors that are contributors. Probably at the top of the list is smoking, but the other ones are the ones that are concerned of this conference: sedentary behaviors. Particularly in rural areas, we've seen over the past 4 or 5 decades a dramatic decrease in occupational physical activities. If you think about the key activities in rural areas, they've been farming and logging, and these days machines do most of that work. But nonetheless, there continues in rural areas to be a high-fat, high-calorie diet, and I think as a consequence, in the reduction in physical activity, but the maintenance of the eating behaviors, we've seen a rise in obesity in rural areas. A few years ago, we looked at this issue of the prevalence of obesity in rural areas, and there are survey data from the National Interview Survey that suggested it was slightly higher in rural areas. So my colleagues and I, one of the things we did was we used the Haynes data and looked at that subset of data where there are actually measured heights and weights, And lo and behold, you can see that the difference between urban and rural areas is actually greater. It's about a 6% difference between the two, with higher rates of obesity in rural areas. Now, most of you know that probably the gold standard for non-surgical, non-pharmacological treatment of obesity are behavioral or lifestyle interventions. And these focus on changes in energy balance by getting people typically to decrease intake and increase their expenditure of energy. And this is accomplished through the use of behavioral strategies that focus on changes in diet and exercise. And these programs have been around a very long time, and we have hundreds of studies that really document the impact of them. The initial weight losses that are usually accomplished are somewhere in the neighborhood of 8% or 8 kilograms. And then when you follow people out, there's a gradual but steady regain of about 2 kilograms per year. Sometimes it flattens out the curve a little bit, sometimes it doesn't. But nonetheless, you see associated with the changes improvements in blood pressure, blood glucose, blood lipids, and other health indicators. And there's been several large-scale studies that show that weight losses of this magnitude can prevent or delay the onset of diabetes in at-risk individuals. And one of the interesting findings from the DPP, the Diabetes Prevention Program, is that over the course of 10 years, the mean weight changes went back to baseline. But over the course of that decade, the cumulative incidence of diabetes was still significantly lower. And so what it suggests is that exposure to being at a lower weight, even for periods of time, and if that changes back to baseline weight, still has a beneficial impact on health over the long run. So it's better to lose and regain than to have never lost at all. Okay, most of you are probably familiar with the key components of lifestyle and behavioral treatment. Individualized goal setting. Typically, it's in the neighborhood of 1,200 calories a day for women, 15 for men. Adding physical activity, usually a starting point is trying to get people to increase by 150 minutes or more per week of exercise, typically in the form of walking. A critical component is written self-monitoring. Daily written logs of various eating and exercise behaviors. And that's coupled with then evaluating the feedback from the logs so as to either self-reinforce and say, geez, I'm doing a good job there, or to cycle into a brainstorming about how can I get my behavior in line with my goal. There's also training in stimulus control, how to avoid triggers for overeating, how to rearrange your environment to promote healthy behaviors. There's also been a focus on changing diet composition, typically targeting decreases in saturated fats and simple sugars, increasing complex carbohydrates, fiber, fruits, and vegetables, and increasing physical activity, as we said. Also, it involves strategies to get others to help out on the process, particularly family members. There's cognitive modification or cognitive reframing, decreasing negative thoughts and trying to develop positive mindset, and then structured problem-solving approaches. This is a pretty consistent package that's been used in multiple studies, as I said, probably hundreds of studies over time. The problem with that package, if you will, is that it hasn't been translated in a form that it can be disseminated and implemented in community settings. And so one of the things that we're trying to do is to try to address that issue. And part of this issue is related to the notion of efficacy versus effectiveness. Efficacy studies are those studies typically conducted almost under ideal circumstances, usually in an academic health science center. The interventions are led by, if not directed by, doctoral level experts. The participants are usually highly selected middle-class volunteers from urban and suburban areas. In contrast, in effectiveness studies, we would conduct those under real-world conditions, usually community settings. We'd have the interventions led by usual care providers, and we'd want to have broad and open participation to most members of the community. So as we've heard from several other speakers, there's a lot of potential, I think, for the Cooperative Extension Service. You already heard from the speaker prior to me that this is a partnership of federal, county and land-grant universities. And originally the mission was pretty much targeted to the application of agricultural research, but it's been broadened over the years, and certainly nutrition education is an important component. But this is an incredible infrastructure that's out there. There are cooperative extension offices in more than 3,000 counties of the U.S. That's virtually all the counties in the U.S. In rural communities, they have a very high visibility, and these are culturally accepted places to go and get assistance. So I think it makes for an ideal venue, potentially, for delivering lifestyle interventions. Now, as we sought to think about translating lifestyle interventions into rural communities, we conducted a series of focus groups, and we heard issues that were of particular concern. And the focus groups were all women, by the way. But part of the things that they were concerned about was that they had a history of southern cooking or country cooking, where they could take any vegetable and turn it into a high-fat food. Where there were barriers to exercise, and it's not that the barriers were issues related to crime, but there are no walking paths, there are no exercise facilities, and if you walk on the road, you're likely to get hit by a red pickup truck. And then they also reported there's limited support for weight loss, particularly a lack of family support for participation. And a lot of times the support, they believed, came from a fear from the other people in the family that they would be asked to change as well, and they may not have been interested in changing. So we tried to incorporate some of these issues into modifying our lifestyle program. The first trial that we did of this type was called the TOURS trial, Treatment of Obesity in Underserved Rural Settings. This was an intensive, group-based behavioral intervention. It was delivered by county extension agents, and if there wasn't one available, we hired a bachelor's level staff member. It involved 50 sessions over 18 months, 24 initial sessions followed by 26 biweekly sessions along the lines of the Look Ahead study. And we got, I have to say, better changes than we expected in weight. We had mean losses of 10 kilograms from baseline to 6 months, and then from baseline to 18 months, we saw a slight regaining to a net of 0.8 kilograms. And so the implications were that cooperative extension offices could be a good venue for disseminating lifestyle interventions, and also that bachelor's level providers can be trained to deliver weight management interventions in an effective manner. So I was feeling pretty good until I gave a presentation to directors of cooperative extension service offices. And essentially they said, we would never implement your program. And the reason for that is they said that the amount of resources to mount that kind of program with respect to interventionist time, agent time, was way too much. They could not see themselves dedicating that amount of agent time because they would want to have a broader reach in terms of reach more people. And they talked a little bit about, well, we actually surveyed all 67 county directors, and we found that those counties that were actually putting on programs like this typically put them on in 8 to 10 sessions, but there are only about 10% of the counties that were offering weight management services. When we asked them what they saw as the maximum feasible, they said 16 sessions, and they saw our 24 sessions for initial treatment as being too high. So we designed this trial, the Rural Light trial, essentially asking if we could reduce the dose of treatment and get a good effect. And we also want to look at the dose that's commonly used, the low dose, and see what kind of benefits were associated with that. So the trial was a randomized trial, and participants were assigned to one of these 4 treatments, high, moderate, and low doses. So the high dose was 24 initial sessions and 24 additional sessions. And then we cut it by a third for the moderate dose, which was the amount the directors said was the most they could consider. We cut it by another third to mimic the low dose. And then we had an educational control group that got information about best practices for diet and exercise, but did not include behavioral strategies. In particular, they were not expected to self-monitor. The goals for the participants were that they improve the quality of their diet, that they increase their physical activity, that they improve the management of stress, particularly because stress can interfere with making the behavioral changes, and that they control their weight. We wanted them at a minimum to prevent further weight gain, and then hopefully also achieve weight loss. We had group sessions, 5 to 15 participants per group, 90 minutes in length, We had 10 rural counties participating in northern Florida, and then I told you a little bit about the family and consumer science agents. But one of the points I want to emphasize is we did a lot of training of the group leaders. We had bi-monthly, full-day workshops and weekly telephone supervision. Here are our participants. We had 612 participants, 78% women. You can see the mean BMI was pretty high, 36. Average age was 52. And then the race and ethnic background kind of mirrors north central Florida, which is mostly white, but 16% black, 4% Hispanic. Okay, attendance. One of the things you can see here is that there were no differences across the 4 conditions in attendance, and the attendance was pretty high. It ranged from 77% of the scheduled sessions to up to 88% of the sessions. We asked participants at the end of the program to rate how satisfied they were with it, and on a range from 0, not at all satisfied, to 100% satisfied. And you could see the scores ranged from 83 to 90, and there were no differences across conditions in terms of satisfaction. And then here are the weight changes. So let's start with the education control group, and you can see that there was a real benefit to participating in that program. They lost on average 4.1 kilograms. And then when we went to the low dose group, remember it's the same schedule, but only we added the behavioral strategies, you get a bump up to 7.2%. So a nice increase, and this difference is statistically significant. We go from 8 sessions of initial treatment to 16 sessions, and you see a further increase here, and this is significant as well. And then when we looked at our high dose, it's an increase, but this difference is not statistically significant. So there was not an advantage in terms of a statistically significant advantage between the moderate and high. We were also interested in the percent of participants who achieved at least a 5% loss, and you could see the same pattern shows up. And the neat thing about this is just the educational program alone produced 45% of those participants achieved 5% losses. You add in the behavioral strategies and you bump that up to 63%, and then you extend the program to 16 weeks or to 24 weeks, and you could see the additional benefits that you get from there. So the take-home messages, I think, are that the cooperative extension service may represent an effective infrastructure to deliver lifestyle interventions. I think that it's clear that low-dose treatment has benefits, but it's less effective than moderate dose, and that the moderate dose can produce clinically meaningful reductions in body weight that are similar to the high dose, but at a lower cost. We'll have the 24-month results in November, and we'll be presenting those. And then I think that the importance here is that these findings have the potential to influence policy decisions and how you would want to allocate resources for obesity management. And so I'll stop at that point and just acknowledge the counties and some of the people who made this happen. We have a few minutes for questions.
Based on your outcomes, what response did you get from the extension leaders in terms of going with a little bit higher than what they originally thought might work?
Well, we haven't presented to them yet the 24-month results, and so we're waiting for that. They know the results from 6 months, but they don't know the 24-month results. I think that they'll be happier with that. They'll see that the costs are less with that in terms of person power and dollars.
Ed Frangelo, South Carolina. So it seems like you already know that the high dose is not likely to be acceptable. So then and if you want to have the behavioral components, then the control is not in the running. So that leaves 2 other groups. So I'm curious, based on what you know so far, what do you think was the likely group to push forward? Would the low dose group be better because the overall cost would be less and the potential to distribute it more widely might be greater?
Yeah, so I think actually that's a great question. And I think one of the things that we should do is look at this as a menu of choices rather than a recommendation. because different counties are going to have, say, for example, have different amounts of resources. And if the choice is that they don't have enough resources to put on, say, the moderate dose, if they put on the low dose program, they're still going to get benefits from that. And so I wouldn't want to discourage them from doing that, and I think people will benefit from participating in those programs. So I don't think we should say, here's the answer, this is the one you ought to do, but here are the data that suggest the likely results you get if you make this choice. Thank you very much.